Hello, everyone. Welcome to the Global Gastroenterology. Today, we welcome Dr. Omar. So, thank you so much for your time. Can you please briefly discuss about your roles? Where are you currently working, and what leadership positions you hold?
Thanks, Omar. I'm Omar Elshaarawy. I'm a gastroenterology and hepatology consultant in the Royal Liverpool University Hospital in UK, and I'm associate professor of hepatology, and currently the chair of the international committee of the British Society of Gastroenterology, and the representative of the BSG on the United European Gastroenterology board as a representative. I've been working here in the Royal Liverpool Hospital for the past 5 years, and I'm originally from Egypt.
That's amazing, Doctor. So you hold the leadership roles in British Society of Gastroenterology. Can you please tell us what is British Society of Gastroenterology? And as you mentioned, you are chairing the international chapter, and being the chair of this international chapter. What collaborations you do? How often British Society of Gastroenterology has the meetings, and what international collaborations you are doing?
Yeah. British Society of Gastroenterology is one of the oldest, if not the oldest, society of gastroenterology worldwide. It's established in 1937, so almost 90 years in less than 18 months. A British Society of Gastroenterology has several sections. One of them is the international section. The international section is basically the international front line of the British Society of Gastroenterology, which has a very big charitable role in general. And the international section is leading on this in trying to transfer the expertise and support other like gastroenterologists and societies abroad, especially in low and middle income countries. So we have been doing this for I think at least last 10 years. There's a lot of projects going on in the international level. We been doing lots of training, including international grants for African countries, including Zambia, Sudan, Ethiopia, as well as in Asia as well, with Pakistan, Bangladesh. So there's lots of ongoing projects we can deep dive into later in discussion, but it's very international, and we welcome lots of collaborations even from other countries where people would like us to help and contribute to transfer our expertise and support their progress.
That's really amazing, very interesting to know. So, Doctor, as you mentioned, you are having some support for the low middle income countries. Can you please tell our audience what are the low middle income countries in the Euro, especially?
You mean like what projects we did with specific low middle income countries? Uh, we have previously within Africa supported trainer courses in Cairo in Egypt, and we did as well a very good collaborative project on assessing the inflammatory bowel disease outcomes in Ethiopia, and this has been extended for another 2 years through international grant funds. So most of the projects actually led by colleagues from the UK in collaboration with other colleagues in these countries, and where they apply for international grants, which we offer every 2 years. We just finished this round, and we discussed in our symposium during the annual meeting of the British Society of Gastroenterology the outcomes from the last successful grants. And we just started the new round, and we shortlisted 5 successful projects, which we will fund for the next 2 years, including projects to support nurse training in Lusaka in Zambia, and another project with colleagues in endoscopy training in African countries where they offer some sort of mentoring. We as well we renewed another 2 years for funding for the IBD projects from Ethiopia. So all of these kind of projects are led by colleagues here, like I said, and there has been successful outcomes in terms of, for example, one of the successful projects from the last round was establishing as a endoscopy reporting software in one of the very deprived areas, and I think was very successful in terms of producing a structured, clear endoscopy reporting with a clear plan for patients. Before that, the patient had handwritten, unclear, very ambiguous reports, which is not and not auditable as well. So we managed to help them to have a software where it would be like helping auditing the outcomes, monitoring patients, clear plans for their patients, including as well photo documentation for their patients. So it's lots of projects and lots of memorandum of understanding, so we can as well explore the memorandum of understanding with different countries, where is it ongoing collaboration both ways actually as well.
That's really amazing. So just for our audience, if someone from other countries want to collaborate with you, what's the process? And is there any website for the registration, and how does it works?
So the British Society website has a dedicated page for the international section, where you can find the calls for the international grant applications, which opens every 2 years. Unfortunately, just finished for this year, and it will be again in 2 years from now. But there is ongoing projects which can be proposed as well. If we can support them, we can approach the zonal leads. So in the structure of the international section, we have zonal leads. So there's a lead for Middle East and North Africa. There's a lead for Asia. There's a lead for South America. There's a lead for specific for India and China. So they can approach the zonal leads, which you can find clear listed on our website, bsg.org, and then you can actually see on the landing page the names of the zonal leads, and you can approach them to propose a project. Sometimes the project is not at the moment of interest, but maybe of interest in the future. So this is something which I really recommend for people to do, is to contact the zonal leads if they have a project or idea that would like collaboration with the BSG, or ask for advice for establishing a course. We had already something from Saudi Arabia asking. It's not a lower middle income country, but they have some sort of demand in terms of trainers for their nurses. So they want expertise. They don't want funds. They need expertise and support in terms of structure and process. So they approached us through our zonal lead, and our zonal lead kindly proposed this project to us. And we are at the moment discussing getting this project done. Hopefully in the next year, we'll go to a trainer course for the nurses, so you can support the endoscopy units there. So we're uplifting their workforce basically. So yeah, if anyone have any idea would like collaboration or support from the BSG, we're welcome to hear and see what capacity we can support. They can approach the zonal leads, like I said, and they can check this on the website bsg.org.uk. And we're looking forward to collaboration with everyone.
That's interesting. Thank you, Doctor, for the clarification. So, being on these leadership roles and having the global perspectives, what do you think? What's the most of the challenges in the digestive health all over the world?
So I think the challenges at the moment is more about the non-communicable diseases. So including, for example, from my specialty or my focus point, which is the hepatology, the MASLD, the metabolic associated steatotic liver disease. This is now representing here, at least in the UK, around 25% of the population. And I think the challenges would be early detection of these non-communicable diseases, including the steatosis in the community in general. So it's not now in hepatology, the target is not to treat the patients and when they come to present you at the end stages. I think we are focusing more now on early detection of their patients. So you need to find ways to early detect and screen the population. At the same time, with the restrictions for funding and all of this, it will be the challenges to find a cost-effective way to screen patients for such non-communicable diseases, including metabolic associated steatotic liver disease. So this is one of the most important aspects in gastroenterology, and I think a bigger concern would be the role of AI and trying to have a ethical implementation of AI in medicine in general, and specifically in gastroenterology, where now there is a growing evidence of rules and benefits as well as concerns for both sides for AI in medicine. But I think definitely we need to look into the benefits and to find ways to target the concerns and avoid I would say the bad side of it through pathways, through policies. So I think this is the main issues in general in the global health at the moment.
Interesting, doctor. So now we are talking about the fatty liver, non-alcoholic fatty liver disease. So most of the time, just for our patient educations, and they come to us and they, without dietary modifications, they just want to go for the easy steps and they want the weight loss medications. And does that help some way in the preventing the fatty liver, or how does it work?
So at the moment, there is no clear evidence saying there is actually a randomized trial or something saying the new injectable medications, the GLP-1 agonists, are having a good role in terms of reversing fibrosis. But there is some evidence showing this, but the grade of evidence is not at a level of randomized controlled trials yet. But we think this will be soon as an outcome. However, it is not the end point. Just injections is not the end point, because if you do not have a proper lifestyle change, there is a plateau point where actually your weight loss will stop and you will not able to progress more after time, even without steatotic liver disease or fatty liver disease. It's just in terms of weight loss in general. You need to accompany this medications with proper lifestyle change. So this the mainstay at the moment in practice in UK for everyone we say for fatty liver. Lifestyle change is the most sustainable and important step. I think there's some people have access to the GLP-1 medications, which is good. It can support their weight loss, and definitely it will help the cardiometabolic risk factors, which is the main concern for those patients. But these medications alone is not going to be a magic solution. It should be accompanied with significant lifestyle change. If there is significant lifestyle change, this will be successful. Without it, the medication alone will not be a magic solution. And we see a lot of rebound once they stop as well. So you need to change your lifestyle to maintain the success and to maintain the weight loss journey.
Thank you, doctor. This is really helpful for clearing some of the misunderstandings among our patients. So one of the other questions we often encounter is patient gets the liver fibrosis and they are very dedicated, and they say like, we will do everything to reverse it. So sometimes they have the questions like, is it reversible or not, the liver fibrosis?
Definitely, fibrosis is reversible. And even the old concept of cirrhosis, that it is point of no return. There is point of no return, but it's quite advanced, where there's like significant portal hypertension and significant complications. But fibrosis in general, F1, 2, 3, definitely reversible by etiology control. So if it's viral hepatitis, treating viral hepatitis will reverse it. If it is steatosis induced like a fatty liver or a steatotic liver disease, definitely is reversible by lifestyle change and weight loss and controlling the diabetes if the patient is diabetic. All of this can help reversibility. And so it is not a point of no return here. The point of no return will be very late in when patients has progressed a lot with significant complication, ascites, portal hypertension, where is significant liver damage already happened. But fibrosis is early. You can change. You can adapt your outcomes with lifestyle change, with control of the etiology. If it's autoimmune hepatitis, you need to have proper control of the autoimmune hepatitis, which will definitely reverse. But the point here is, what is the degree of reversibility? This is thing we need to explore, because sometimes you can't really reverse back to normal zero with F0, for example. You can sometimes, but if control of etiology succeed, sometimes you will have significant reduction of progression, significant reduction in risks of complication, and some reversibility, which is good, because a patient have some sort of misunderstanding of the liver disease that is not reversible, and just I'm cirrhotic. I cannot really change anything. I'm end stage. I don't like the word end stage because this is frustrating for patients. Some people tell the patients, I have end stage liver disease. There's no end stage liver disease term. It's very frustrating for the patients. So yeah, there is advanced liver disease, but it is reversible. Try it with your doctor to find out a proper management plan according to your etiology of your liver disease to reverse it back to some degree. We're not saying it's completely reversible, but there is some stages where it is completely reversible.
Thank you, doctor, for the clarification. I hope it will help our audience to understand the etiology and about the reversibility of the liver fibrosis. So now specifically being from the UK and being the hepatologist, what are the top three causes you see for the alcoholic, for the liver cirrhosis?
The main driving factor, I mean, the main
Yes.
etiology. Definitely, it is alcoholic and non-alcoholic steatotic liver disease. So MASLD and ALD. So the main driving factors. And I think this is mostly will be the same in all the Western countries. In developing countries, usually it is viral hepatitis is a driving factor, hepatitis B and C. Now with the curative medication for hepatitis C, I think hepatitis B is emerging more than hepatitis C. So yeah, this is in Western countries, this is definitely MASLD and ALD is a driving factor, sometimes combination, metabolic ALD. So this is a driving in Western countries. I guess would be the same, like I said, in America or in
Yeah.
Europe. So be the same everywhere.
Interesting. And how often you encounters the liver failure patients and how the liver transplant evaluation and the process works in the UK?
So the UK is pretty standard in terms of the care provided for liver disease patients, and tertiary units will receive most of the acute liver failure patients where they manage and try to manage them acutely and try to stabilize them. And if it is not really successful, then we refer to transplant centers where there is actually possibility of liver transplant. However, this kind of discussions is very structured. If the patient fitting the criteria or not, if the and the patient is fitting the criteria, they transfer from tertiary units to transplant units. So transplant is offered in specific dedicated units in the UK. It's very limited number of units which can offer the liver transplant. And the criteria is almost the same everywhere. You can vary in terms of very minor adjustments, but in general, the bigger criteria or the overall criteria is the same everywhere. So no overall discrepancies between centers. And these discussions happen between the tertiary centers and the transplant centers. If the patient fits the criteria, they have inpatient transfer assessment as acute liver failure patient, which is very urgent. And we managed to get successful outcomes for many of our patients who have require transplant for acute liver failure. And with collaboration with our transplant center, which is Birmingham, where we send our patients for the transplant procedures, and they come back to us after the transplant procedure for follow-ups in the Liverpool. We had very positive outcomes for our patients, and I think it will be the same as well for most of the other centers because, like I said, it's almost the same structured pathways everywhere in the UK.
All right. Thank you. So for the liver transplant, it's for the live donor transplantation. For example, if some family members gets the liver failure and other family member is willing to donate the liver, how does it work? Or it's just it goes to the donors directory and whoever gets the match, they get the liver transplant.
So it's a bit complex than this. I think most of liver transplant procedures done in the UK is not living donor. It is almost the cadaveric, so who gets a full liver from another donor. But sometimes some cases where living donor transplant is feasible, where there is matching relative or there is some sort of feasibility in terms of as well the clinical readiness for the patient, because the living donor transplant is more complex than the cadaveric because you are providing portion of the liver, and the physical status and the condition of the patient probably need to be much better than the cadaveric transplant. As well as you have to bear in mind the quality of the transplanted liver, the readiness of the donor. You don't want to go the procedure with one sick patient and end up with two sick patients after the procedure, or come back again with one sick, which will be the donor. So we need to make sure that the donor is safe as well as the recipient. So liver donor transplant is not that common, and I think it would be an option only in very limited circumstances. And probably my colleagues in the transplant center would be able to comment this in more focus, because definitely they encounter this kind of situations quite more often than us. But from our experience, for our patient we referred, we have very limited number of patients who had a living donor transplant. Most of the patients had a cadaveric liver transplant.
Interesting. Doctor, would you like to mention some centers for the liver transplant in the UK that are like provide the best care according to you?
Like I said, all the centers in the UK almost have the same quality of care provided, because it's all audited and there's the same pathway and structure. So I think from the last transplant meeting, for the annual transplant meeting in the British Society of Study of Liver, outcomes was not really different from one center to another, so almost have the same outcomes. The only difference would be the waiting time according to the referrals from the areas, and I think this is somehow manageable because by cross transferring patients, if the patient is in between two centers, sometimes it's easier to reach this center as other center. So the only thing would be the waiting time. Sometimes it's the only bigger difference, but the quality of care and the outcomes the same in all the transplant centers in the UK.
Interesting. So, doctor, now we are just talking about these disparities, and what do you think? What are the challenges people have in UK seeing a specialist like hepatologist? Is there a long wait time, or are there some insurance issues? How does it work? What are the challenges for the patient?
So in the UK here, the NHS is covering everyone. So there's no insurance issues here, because it's not you don't have to pay to get seen or to pay for insurance cover or anything like this. So NHS is covering everyone for all the medical care required. And some units where there is not enough workforce, they might have in challenging like a situation in terms of finding appointments for their patients. However, within our unit, it's for routine. It take you around 12 weeks for routine appointments. But in urgent appointments, you can be seen within 2 weeks usually, if you have an urgent liver condition. I think the challenges could be tackled with some sort of improving the communication between primary and secondary care to avoid unnecessary referrals or incomplete referrals. So I think now there is lots of investment in advice and guidance between secondary care and primary care, where you advise the secondary care will provide advice and guidance to the primary care led by consultants. We give them the plan and try to limit the number of appointments unnecessary for a patient before they come to the service. And once the patient comes to the service, they have all their investigations done, so they can have a appropriate assessment and the plan from the first appointment. I think this is the things which is already now emerging, so making sure that all the communication between primary and secondary care are appropriate, having educational sessions for primary care to keep them updated about the management of liver disease patients, so will not result in inappropriate referrals that would increase the waiting time and the waiting lists, and only be you have only the patient who need really to be seen in secondary care.
Thank you, doctor. So, like as we were talking about avoiding the unnecessary referrals, I would like to know your opinion for our primary care providers. What should be the cutoff point, and what should be the comfort level of primary care providers for the liver fibrosis patients? Like, this is I feel comfortable managing these things, and now this is the time I should send him to a specialist for a liver fibrosis specialist.
Yeah, so I think there's clear pathways in the integrated care boards across the UK. So there is for example, for us here, we currently looking at the updating the pathways for liver disease in general. But at the moment, for example, anyone with FIB4 above 1.36, they, for example, this is a risk of fibrosis. So they do a request from us to do a fibroscan, and we do a fibroscan to assess liver fibrosis and rule out causes of liver disease in terms of viral hepatitis. We as well look into the autoimmune markers, all of these kind of things. But we're looking at changing this to age-adapted FIB4 to try to minimize the number of unnecessary failures, because just the regular FIB4 results in too many false positive patients. So we are looking at changing this as well, and looking at when it is comfortable for us to refer back the patient to primary care. Once we do all this kind of assessments, it is at the moment we keep everyone with, for example, for steatotic liver disease with liver stiffness 8 kilopascals. We think there's no need to keep in service for just the advice would be change your lifestyle, weight loss, and maybe we come back again 2 years to assess the liver stiffness again. Not necessary to keep you in service. So it's looking at increasing the cutoff value for 10, for example, but it is still in discussion. So like I said, it is important to have a structured pathway. So at the moment, there is a structured pathway, but we're looking into changing it because it is resulting in too many unnecessary referrals. And the process for getting this looked at is structured as well, because it is representatives from the patients, representatives from primary care, representatives from various centers across the integrated care board, where they will meet and agree on definite cutoff values for referring and transferring back the patient to primary care as well, to result in an appropriate plan for our patient and the standard for everyone. So me and you will get the same care at the end.
And that's interesting. Thank you so much, doctor. We try to clarify a lot of the misconceptions to make the people understand the healthcare better for the digestive health. Thank you so much. It's really valuable. So the last question I ask all of my guests. So you have a lot of international exposure. You meet a lot of young mid-career, like in the late career, gastroenterologists and healthcare providers. What's your advice for them?
First of all, I would recommend them to attend meetings where there is updates. Keep yourself updated. Connect with other colleagues. Don't fear the communication. Communication is very important. This will result in collaboration, learning opportunities, training opportunities. So communication is very important. At the same time, focus on executing 1 or 2 projects first before adding another 3rd project for yourself. So if you have 1 or 2 hanging projects already, just focus on them, get them done, finished. It will be rewarding for yourself. At the same time, will give you more focus. So don't bite more than you can chew. And at the same time, I would recommend like asking for mentorship. So mentoring is very important. Always you can look at things in a different perspective from a mentor point of view, and someone will give you their advice about what they've been through and what would be the best decision in the situation you are facing. I still have my mentors. I still have ongoing discussions with my mentors. Either in UK, in Germany where I worked and I had my PhD, or in Egypt. So I still have my mentors, still ask them their advice from time to time, because this is important. They've been there longer than me, so they know what the challenges I'm facing at the moment, and they provide better advice. So have a mentor, communicate well with all your colleagues, juniors, seniors, everyone. Communicate well, and keep yourself updated by attending educational events and meetings.
All right. Thank you so much, doctor. It was really amazing to talk to you and discuss a lot of points. I am really thankful for your time, and it was a pleasure meeting you.
Thank you, Omar. Same here. I'm very pleased with this conversation today, and hopefully this podcast will be helpful for all our audience.
Thank you so much. Have a good evening.
You too. Thank you. Thank you.